Meli Orthopedics presents ACL Reconstruction of the Knee. This video will provide detailed information about the anterior cruciate ligament, including its injuries, diagnosis, and treatment. But before watching this video, it is highly recommended that you first watch the video entitled Introduction to Knee Arthroscopy, which can be found at paulmeli.com and on YouTube. Introduction to Knee Arthroscopy will provide basic knee anatomy and arthroscopy knowledge, which will serve as a foundation for this video. To provide clarity within this video, some basic knowledge of medical terms or medical terminology is required. For the purpose of medical terminology, the human body is divided into several planes. One plane divides the body into the front side and the back side. The medical term anterior refers to the front side, and posterior refers to the back side. Another plane divides the body into the left side and right sides. To describe things close to or near the center of the body, the term medial is used. To describe things further away from the center line of the body, or closer to the outside edges of the body, the term lateral is used. These basic terms will be used frequently throughout this video. The knee joint is where two of the largest bones in the body meet to create a hinge-type joint. The femur is the upper bone, and the tibia is the lower leg bone. The knee is stabilized by several ligaments, including the collateral ligaments, which are located on both the medial and lateral sides of the knee joint. There are also two cruciate ligaments located in the center of the knee joint, within the intercondylar notch of the femur. These two ligaments are the anterior cruciate ligament, or ACL, and the posterior cruciate ligament, or PCL. Together they form a cross, or X, which is where the Latin term cruciate derives. Both the ACL and the PCL attach to the femur and the tibia, although in very different anatomic locations. The cruciate ligaments are responsible for the majority of the knee's stability in the anterior and posterior planes. A patient with a torn ACL will have anterior instability, and the tibia will shift forward or anteriorly when stress is applied. Conversely, when the PCL is torn, the tibia will shift posteriorly or to the rear. While it is possible to tear or damage either the ACL or the PCL is injured in over 95% of all cruciate ligament injuries. Therefore, the ACL will be the focus of this video. ACL tears. Most ACL tears occur at their attachment to the femur. Mid-substance tears of the ACL are the second most common location for tears, and the tibial attachment of the ACL is the least frequently damaged. The most common mechanism of injury to the ACL is the result of the knee being flexed with severe external tibial rotation, as seen here. Most patients who suffer a tear of the ACL will describe a popping sensation at the moment of injury. This is soon followed by knee stiffness and swelling, which is the result of the knee joint slowly filling with blood from the torn ligament. Immediate knee treatment should include RICE, rest, ice, compression, and elevation. Diagnosis and treatment. A patient who feels that they may have suffered an ACL tear should consult with an orthopedic surgeon. X-rays of the knee will be performed, although it is important to note that a torn ACL will not be visible on X-ray. The X-ray is done primarily to rule out fractures or other bone abnormalities. The surgeon will perform an examination on the knee and may order an MRI scan to review the cruciate ligaments and meniscus. If the ACL tear is acute, the surgeon may attempt to aspirate the knee. This is done by inserting a needle with a syringe attached into the knee to remove the blood, which will reduce the stiffness and swelling. If the surgeon gets blood in the syringe, this serves as an indication that the ACL is torn. But if normal, clear, yellow joint fluid is removed from the knee, an ACL tear is less likely. If the diagnosis of a torn ACL is confirmed, reconstruction surgery is usually indicated. Today, most torn ACLs are reconstructed, as decades of research have shown that untreated ACL tears may go on to create future meniscal tears, arthritis, and other knee damage. All ACL reconstruction surgeries use a substitute material to recreate the ACL's function. These are known as ACL grafts. Many materials have been used for ACL reconstruction, but currently only human tissue is used for ACL grafts. Tissue taken from the patient requiring the ACL reconstruction is known as an autograft. Tissue donated by cadavers is known as an allograft. Allograft tissues have a long history of safety and success and are used in a variety of anatomic locations, such as heart valves, corneas, bone grafts, and more. The risks associated with allograft tissue are very low due to improvements in processing and screening. Human tissue used for ACL grafts: patellar tendon, hamstring tendons, which are comprised of both the gracilis and semitendinosus tendons, Achilles tendon, quadriceps tendon, and tibialis tendon. With so many tissue options, the choice may seem daunting, but if we eliminate the two least common, we are left with three very common human tissues used for ACL grafts today. These are patellar tendon, hamstring tendons, and tibialis tendon. Each of these grafts have been used for decades with great success, and each has also been exhaustively studied and proven effective. If you are considering ACL reconstruction, please discuss any graft concerns you may have with your surgeon. Regardless of which graft is chosen, all ACL reconstruction has a common goal, which is to recreate the correct anatomic placement of the ACL within the knee. ACL reconstruction requires that bone tunnels be made in both the tibia and the femur, which will contain the graft. Correct placement of the graft within the bony tunnels is of paramount importance, as a few millimeters of deviation from the correct location will place unnatural forces upon the graft and its fixation, causing failure. ACL fixation hardware. The most common method of graft fixation is the interference screw. These are made of either metal or bioabsorbable materials. Interference screws are placed parallel to the graft and in the bone tunnels of either the femur and/or the tibia. These screws cause the graft to compress tightly against the walls of the tunnel, which holds the graft firmly in place until healing occurs. The second most common method of graft fixation is the button. Buttons are usually made of metal. The graft of choice is passed through the loop in the button. Then the graft with the button is passed through the bone of the femur. The button flattens on the hard cortical bone of the femur to secure the graft. There is a great variety of other fixation devices available. These can range from specially designed devices to commonly used surgical staples, screws, and washers. Any of these fixation devices may be used, and the surgeon may even use one method in the femur and another in the tibia, based upon their personal preferences. All fixation devices are designed to provide only temporary fixation until the graft becomes incorporated by the bone. Currently, Dr. Meli prefers the all-inside technique of ACL reconstruction, which has been pioneered by the Arthrex Corporation. This technique uses buttons placed on the cortex of the bone to secure an allograft hamstring tendon into the bony tunnels. ACL reconstruction is performed in an operating room and is not an office-based procedure. ACL reconstruction is performed arthroscopically. Arthroscopic ACL reconstruction is an outpatient procedure. meaning that you will return home several hours after your surgery. The surgery begins with the patient securely placed on the surgical table under general anesthesia. The surgeon then performs an examination of the knee under anesthesia. A tourniquet is placed on the upper thigh and will be inflated later to minimize bleeding during the surgery. The leg is then secured in a holding device which will stabilize the knee. The knee is then cleaned with a skin cleansing agent and sterile drapes are applied to create a sterile field. An elastic bandage is applied to the leg to squeeze out as much blood as possible. Then the tourniquet is inflated to control bleeding. Small incisions are made for the fluid inflow and for the arthroscope. A thorough inspection of the knee is performed. ACL tears are frequently accompanied by tears of the meniscus, so both the medial and lateral meniscus are carefully examined and treated as indicated. Then the arthroscope is directed to the intercondylar notch of the femur, where the ACL and PCL are located. This patient has a torn ACL. Notice how the ACL is lax and how it is not under tension as it should be. With the diagnosis of a torn ACL confirmed, the ACL reconstruction begins by removing the remaining ACL tissue with a motorized shaver and an electrocautery device. The intercondylar notch is then slightly widened with a motorized burr. This is done to ensure that the new ACL graft will not be impinging upon the edges of the notch. First, the surgeon places the drill guide on the femur and locks it in place. The position of this guide within the notch is extremely important. The drill guide is placed against the bone. A specialized tunnel drilling device is passed through the femur from outside of the joint to the inside of the joint. After removing the guide, the drill sleeve is tapped into the femur. Then the blade at the end of the drill is opened into the cutting position and drilled into the bone, creating a hollow tunnel in the bone. The drill is stopped when it meets the tip of the drill sleeve. Then it is collapsed and removed. A suture is passed through the drill sleeve and through the previously created bone tunnel. The suture loops are pulled outside of the knee. A second drill guide is placed in a specific anatomic location on the tibia. Then, the tunnel drilling and suture passage steps are repeated in the tibia. These sutures are used to pass the prepared graft that will ultimately replace the ligament. The suture with the button attached to the graft is pulled through the femur. The button is flipped, and it catches firmly on the bone. The tensioning sutures are then sequentially pulled to draw the graft into the bone tunnel of the femur. The sutures from the tibial tunnel are then loaded with the other end of the graft, and then the graft is drawn into the tibial tunnel. A button is added to the sutures on the tibia. Then the graft is sequentially tightened into the tibial tunnel. Finally, both sides of the graft are given a final tensioning. The sutures are then tied on the tibial button and cut. The small incisions are closed with suture. Dressings are placed on the wounds, and a hinged knee brace is fitted to the patient. This will allow a controlled and progressive range of motion during rehabilitation. The patient is awakened and transported to the post-surgical unit. There you will be given crutches and your surgeon's instructions for your post-surgical care. We hope that you have enjoyed this video from Paul Meli Orthopedics. Please visit paulmeli.com for more videos and information about your orthopedic care.